It's always important for us to know what to do for a patient that has stopped responding to a drug. And for example, idelalisib targets the PI3K signaling pathway, which is part of the B-cell receptor pathway. Ibrutinib targets also the B-cell receptor pathway, but through a different target, which is the BTK, and through BTK inhibition. So even though you develop that refractoriness or you progress to this drug that targets the PI3K, you can still salvage someone with a different B-cell receptor signaling inhibitor that targets a different or an alternate pathway. So now we have to figure out if those patients, for example, that are treated with ibrutinib can then be salvaged with the other drug, with a drug such as idelalisib, or in the case of newer agents, there's a new drug called duvelisib, which is a PI3K gamma delta inhibitor. And right now, there's a clinical trial for patients that have stopped responding to ibrutinib and that can be then, in a clinical trial, use a combination of duvelisib with a monoclonal antibody called tovinotuzumab. So we don't know if that will work, but there's anecdotal data that was presented at last year's ASH, where 5 people were treated with duvelisib as a single agent, and 2 of them had actually a response after they failed ibrutinib. So it may be possible to move from one to the other. And what we will see at this year's ASH is the data on a drug like venetoclax, where people that had failed ibrutinib and idelalisib have been salvaged successfully in a very short period of time and a short number of patients. But it's very promising that you can usually, there's evidence that you can target a different signaling mechanism. This is not an inhibitor of the B-cell receptor. This is now an anti-apoptotic drug. But you can salvage with a different agent. And that's all important because even though people are now being in remission longer with these drugs, we still have to figure out what to do next once they stop responding.